Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. Today, we'll be discussing COVID-19 antivirals and treatment updates. Everyone has entered the meeting on mute, but we will have a discussion at the end of this webinar. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We encourage you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be discussing the White House administration's winter playbook for nursing homes. My name is Kathy Caudell. I'm a communications specialist with Quality Insights. And now I'd like to introduce our guest today, Dr. Krista Capehart. Dr. Capehart is a clinical professor in the Department of Clinical Pharmacy and director of the Winger Institute for Advanced Pharmacy Practice, Education, and Research at West Virginia University School of Pharmacy. She is also the director of Professional and Regulatory Affairs at the West Virginia Board of Pharmacy. Dr. Capehart also serves as the pharmacy lead for the West Virginia Joint Interagency Task Force for COVID-19 vaccine and therapeutics distribution. Dr. Capehart, welcome and thank you for joining us today.
Sure. Thanks so much for having me. I look forward to bringing you this information. We've actually recently had some updates as of actually the 29th of December. So getting some new information out there and looking forward to getting that information and sharing it with everyone today. So we'll go ahead and get started and then we'll have time for some discussion at the end. So what we're going to cover today, we're going to look at our current treatment guidelines for COVID-19. We've had a lot of changes throughout we're approaching 3 years with COVID-19 now. And so we're going to talk about our current medications that we have available and really where those fit in line when you have that patient before you and how do you make those determinations. We're going to look at appropriate use with each of those medications, what would be the monitoring, and really how do you select one and then manage those given, some of these medications have a great deal of drug-drug interactions that are making clinicians really reluctant to use some of them. So we're going to really spread the gamut of things today, bring you some new information, and then kind of what may be on the horizon. So I want to start, I know, I think everybody in the state is probably tired of me talking about them, but I will always go back here. Vaccination and vaccines are our first and foremost important tool in our toolbox, especially in our long-term care and nursing home population. We have our bivalent, so that's our newest booster. It, of course, is made up of the original strain, which is the monovalent, and then it also has that bivalent component, which is made up of the BA.4, BA.5. So the individual is getting both of those. So you do see, the patient needs to have completed the primary series and then wait 2 months, and then they're eligible for this bivalent booster. Now, you can see here in our patients 12 years and older, they could have completed a Moderna, a Novavax, or a Pfizer primary series, wait 2 months, and then get a bivalent messenger RNA booster. Does not matter how many monovalent boosters they've had. We're basically doing a reset to get that bivalent booster. Also, if they got a Janssen dose, then they would get that bivalent booster 2 months later. And just to kind of get you set and thinking, the newest variants that are out there that are kind of taking over, we don't think they're the predominant variant here in West Virginia right now, but it is the first US variant. It's XXB, It's still an Omicron variant, so we're still talking about coming off that same branch. So it's not a BA4 or 5, but it's still an Omicron variant. So we do anticipate we'll still have that cross coverage and protection to some degree. But so still want to get those patients vaccinated. So let's look at for immunocompromised, which is our next slide. So in our immunocompromised patients, remember, we anticipate that they might not respond as well to our vaccines. So 12 and older, their primary series looked a little different. Moderna, Pfizer, they had 3 primary doses as their primary series. Wait 2 months, get a bivalent booster. Novavax, they had 2 primary doses and then wait 2 months and a bivalent. And then if they got Janssen, they were supposed to get a primary dose of Janssen, wait 4 weeks, a messenger RNA messenger RNA monovalent, then wait 2 months and get a bivalent booster. And I'll touch on this at the end, but we don't utilize monoclonal antibodies anymore for COVID treatment. None of the monoclonals work anymore to treat COVID. However, we do still have one product called Evusheld that is used in the moderate to severe immunocompromised that we can use for pre-exposure prophylaxis. So think of this as our second tool in the toolbox for our immunocompromised patients. 12 years and older, they can get vaccinated, then wait 2 weeks, get an Evusheld dose. We do have plenty of Evusheld here in West Virginia. So if you have that patient that is moderate to severe immunocompromised, think about getting them Evusheld. It is starting to lose its effectiveness, but in this population, we really want to do as much as we can to keep them safe. All right, next slide. So wanted to just remind everybody as we start talking about how we're going to treat it, there's really 2 things that drive the course of COVID-19. The first few days, and actually it varies a little bit with each variant that we see, is this replication of the SARS-CoV-2. And the drugs that we have to use at the early stages, they are inhibiting that replication of SARS-CoV-2, and we'll talk about those. And then later on, what happens in that pathogenesis, you get the dysregulation of the immune and inflammatory response. And what happens then is that leads to tissue damage. And so you will see different courses of treatment and different stages of the disease as patients progress. So I will talk a lot about if these patients are at increased risk of disease progression. And in the nursing home, most of our patients are at increased risk of disease progression because one of our first criteria that we look at is older age. You'll see that as over 50. I'm getting really close to that, so that one makes me a little nervous. But most of the time we think of it as 65 and older, but we are starting to inch that down a little bit in terms of treatment. Prolonged amount of time since the most recent vaccine dose, so definitely if it's been more than 6 months. And then if we expect that they're going to have a decreased likelihood that they have an adequate immune response, whether they have moderate to severe immunocompromised condition, maybe they take immunosuppressive drugs, all of those kinds of things. And the more of these things that you add on, the more likely that you would have increased severe disease progression. And so you're going to be more likely to treat. Let's go ahead. So I mentioned that your treatment guidelines just recently changed. And so this, we did get new National Institute of Health treatment guidelines that came out as of December 29th. They do review those, or excuse me, December 28th. They do review those very, very regularly. especially because of the monoclonals. If we will remember, gosh, back in last spring, at one point, I think we had 4 monoclonal antibodies that we could utilize to treat based off of different variants. However, those started dropping off pretty quickly. Now we have no monoclonal antibody that is a treatment option for any of the variants that are currently out there. So for all for all patients, I'm going to focus on our non-hospitalized adults with COVID-19. I'm going to touch on the hospitalized, but really focus on our non-hospitalized patients. Oh, go back one, just a second. That's okay. Going to focus on our non-hospitalized patients, simply because when they're in our nursing homes, yes, they're in congregate care settings, but they're definitely not hospitalized. So how can we keep them from getting hospitalized with COVID-19? So you want to manage whatever symptoms they're having, cough, fever, etc. One thing that came out and was stressed significantly with this new set of guidelines is that the panel is recommending against the use of dexamethasone or other systemic steroids, unless the patient has another indication for them. So if they have some other type of condition where you would, where you're already going to be using steroids, then it would be okay. But they are actually now recommending to not start steroids in this type of patient at this point. So if you have a patient who's at high risk of progressing to severe COVID-19, now most of our nursing home patients are probably going to fall into this category, quite honestly, simply because of their age. So this list has changed a lot, even just in the last 6 months. Our preferred therapy at this point in order of preference is our Paxlovid. Now, 6 months ago, 8 months ago, everybody was really nervous because there are a lot of drug-drug interactions with Paxlovid. But I want to talk to you about how you can manage them, what are your therapeutic options, and how can we still get these patients treatment safely and effectively. Your second option then would be Remdesivir. You might remember Remdesivir was one of the first treatments we had, but it was only authorized for inpatient use. We do now have it as an outpatient option. It is still infusion though, and so and you have to. There's some special things that you have to be aware of. And then the third for your non-hospitalized patients is molnupiravir, and we'll talk a little bit about that. And that's only to be used, though, if your Paxlovid and Remdesivir are not options. Okay, so let's go ahead. And I'm going to go ahead to the next slide, and I'm going to stress again, because I know in so many of these patients that, and actually since we've been treating COVID, that one of the first things that we have been, our inclination is to add on steroids. And that is no longer a recommendation in outpatient because there's actually evidence now that that could actually cause harm if there is no, if there's no other use, or excuse me, no other reason for the use of steroids in these patients. All right, so let's talk about Paxlovid. Paxlovid has now become our first-line treatment in most patients. It was granted emergency use authorization just prior to Christmas last year. I remember because I spent almost all Christmas, the time between Christmas and New Year's, preparing tools for people to use to safely prescribe it and dispense it. So we're talking about mild to moderate COVID in adults and pediatrics 12 years and older, weighing at least 40 kilos. They need to have a positive COVID viral test. So we, it can be an antigen test. It doesn't have to be PCR. And then they need to be at high risk of progression. So realize that, we're not using it for prophylaxis. if they've been exposed. We're using it if they have a positive test and they're at high risk for progressing to severe COVID. You do have to start it within 5 days of start of symptoms or a positive test, whichever sooner. We have two types of doses. There's standard dosing if there's no known or suspected renal impairment or just minor renal impairment, in which case the classification for mild renal impairment with this drug is an estimated GFR of between 60 and 90 milliliters per minute. And then renal dosing is greater than 30, so between 30 and 60. And so basically you're looking at, it has to be started within 5 days. Now, the reason that this is important is because remember when we talked about the pathogenesis of the drug, of the course of COVID, this drug is going to inhibit the viral replication. So the sooner you get it on board, the better it's going to work. And so it inhibits that replication. So if you test as soon as you're having symptoms, then get 5 days of treatment on, really going to be able to best likelihood of keeping that patient from progressing to severe disease, which is really what we want. So standard dosing, it's there's actually, they come in packets. And there's three, for standard dosing, there's 3 tablets in the package, 2 Nirmatrelvir 100 milligram tablets, and 1 ritonavir 100 milligram tablet. And they will take all 3 tablets twice a day for 5 days. So it'll be a total of 6 tablets per day. Have a lot of questions about what do you do if the patient has PEG, has an NG tube, can't swallow. Unfortunately, this can't be used. It cannot be cut. It cannot be crushed. Unfortunately, I just had a situation. My father-in-law was very ill, and he was having difficulty swallowing. We were able to actually give him Paxlovid. He was able to get his 3 tablets down in the morning and the evening. That was about all we were able to get down in the, but these cannot be crushed, cut in any way. And that's because of the way that the tablets are formulated. That if you actually break or crush them, it destroys the delivery system. So, and then your renal dosing is one of the Nirmatrelvir, sorry, and one of the Ritanavirs, taken together twice a day, so morning and evening, with or without food, it doesn't matter, for a full 5-day course. And so that's going to be what you can do with your renal patients. And you know, there's some places we don't get as much of an allocation of the renal doses, but your pharmacists know that if you have a standard, if they only have standard in stock, they can actually remove one of the tablets to dispense to your nursing home, so that basically it makes a standard dose down to a renal dose so that we can still get your patients treated. Okay, next slide. So before I go into all of these Paxlovid drug interactions, there are 2 amazing tools out there for you that make this so incredibly easy. The links are here. And literally it's so easy because it tells you not only if there's an interaction, but it gives you step-by-step how to manage them. And we've learned a lot since these drugs came out. It's been out for a year. A lot of medications that we thought were absolute contraindications, we can now manage so we don't like exclude entire classes of medications. All right, so ways we can manage these drugs. So we can increase the monitoring. So maybe it's okay that the patient stays on both of them and we just monitor them a little bit more. Maybe we adjust the dose of the drug that it's going to interact with. Maybe we hold that drug that it's interacting with. Maybe we change it to a different drug for the duration. Or if there's just no way to avoid it, maybe we go to Remdesivir, or if that's not an option, maybe we go to Molnupiravir. In terms of efficacy, Paxlovid probably has the best efficacy, followed by Remdesivir. We do know that Molnupiravir is not as effective as Paxlovid and Remdesivir. Okay. So the reason that Paxlovid has these drug interactions is because the drug is metabolized and interferes at cytochrome P450-3A4. It is both an inducer and is metabolized there. So in terms of medications, these are the ones that are absolute contraindications. There's no way that we can get around them. Carbamazepine, phenytoin, phenobarb, some of your cystic fibrosis drugs, rifampin, and interestingly enough, St. John's wort. So if you have a patient that takes St. John's wort, or even maybe they just like their herbals, make sure and ask, because that is an absolute contraindication with this drug. So let's talk about some where we can stop the drug that they're taking that interacts with Paxlovid for maybe 2 or 3 days, or for a temporary period of time. So you'll see some on here that you're going to think, okay, wait a second, is that really something I would want to withhold? Now, you're going to have to assess that in each individual patient. When you look at your anti-coag drugs, it may not be appropriate to withhold an anti-coag. Maybe you need to switch them over to heparin. Maybe if they are truly at that an increased clotting risk. So you're going to have to assess each individual situation. But so your lipid drugs, you can withhold a statin for a few days. These other salmeterol, okay, you're going to be your inhaled medications for your for your asthma COPD patients. So you're going to have to look at these and see, is it going to be appropriate to withhold those? And in most cases, probably might have to switch them to something else to get through. But like I said, if you go to the specific managing, it will let you know. Okay. All right. Next slide. All right. Now here is one. This whole list is actually really interesting, because this is a list of those where you're going to just adjust the dose and monitor for side effects. So the patient can still stay on both drugs, but you might have to reduce the dose of this drug by half. You might have to reduce it by 25%. So if your patient is on one of these medications, you can go to this link that I give you, and it will tell you how much you need to adjust the dose. Now, if you look, pretty much every single benzodiazepine, as well as almost all of our antipsychotics, are on here, or neuropsychiatric meds. Okay, so if that's an area where a lot of your patients are on, you're going to need to look and see what you're going to need to do. But if these patients truly are at high risk and need the treatment for COVID, you're going to be better off to get them first line. But again, and get it for them as soon as possible versus taking a wait and see approach. Recognizing that COVID replicates very quickly, especially some of the newer variants. So for instance, I mentioned the XXB. It replicates as one of the fastest variants that we've had. And so getting that Paxlovid on board earlier in like day 1, 2, or 3, much better than getting it on day 4 or 5. Still within the emergency use authorization, but much better to get it on early rather than late. Cindy, are you guys, I assume you guys are going to put the slides out. I would assume. I saw the question pop up there. And then also, so I pulled out the National Institute of Health information so that I can like point out some clinical important things and those kinds of things. You can get all of this information dialed down pretty easy to use by going to COVID-19 treatment guidelines.nih.gov. And it has all the links and all of these tables and things too. It's very easy to use. All right, next slide. All right, now these medications, when the drug first came out, we thought that we were not going to be able to take Paxlovid and these medications. Well, I got to tell you, I think half of West Virginia is on some of these felodipine, nifedipine, amlodipine, diltiazem, verapamil, and valsartan. So, and glyburide, I think probably that encompasses the vast majority of West Virginia. That's what I said whenever I first looked at the drug interaction list. I thought, oh my goodness, we're not going to be able to treat anybody in West Virginia with all of these drug interactions. But we've learned so much in the last year about how we can manage. Most of the time with this list, you're going to be able to provide the medication, provide Paxlovid, and simply monitor the patient for any type of adverse events and not make any changes. They're usually going to be just fine. And they're not going to experience anything. And shockingly, this actually includes warfarin, our drug that interacts with everything. So, you know, it's nice to actually say, okay, well, we have some that we're not going to have to make those changes with. All right, go ahead. Okay, so what's going to happen? I have heard all kinds of stories. To kind of give you an idea, we have Paxlovid all over the state of West Virginia. Virtually every pharmacy has it. And if they don't have it, all they have to do is get in touch with me and I can get it to them. We have plenty. The federal government has plenty. And actually in the new omnibus bill they passed, they actually just included to make sure that it would actually, even if it becomes commercialized, it will still be covered by all Medicare Part D plans. So that's a good benefit. But right now we've got plenty of it on the as purchased by the U.S. government. Some of the side effects, altered taste. And I've heard everything from like really metallic to just nothing tastes good. It's a variety. Most of the time, what I hear is abdominal pain, nausea, and diarrhea. Now, in terms of incidence of those who had to stop the drug in studies, it was actually around 2 to 3%. If I hear patients talk about it anecdotally, that's what they tell me was the most significant that they experienced. Okay, all right. Now, I always get this question, you know, the president, the first lady, all these people we've seen on TV have experienced Paxlovid Rebound. Well, what's Paxlovid Rebound? Well, it may not actually be Paxlovid Rebound. So it's defined as completing your course, sometimes testing negative. We do know that antigen testing, we don't actually test to see if you test negative anymore, because we do know you can continue to test positive for a long period of time. But you complete your course and then test positive again 2 to 8 days after completing your 5-day course. It could be Paxlovid, it could be molnupiravir. We do know that it is not unique to Paxlovid, not unique to molnupiravir, and not even unique to those who did not even receive antiviral treatment. It's just received a lot more publicity. The CDC did put out a health alert, making everyone aware. Paxlovid is only, and actually molnupiravir as well, they are only authorized for 1 course. It does not seem to improve outcomes. They've looked at lengthening the course, various things like that, and the studies have not demonstrated that you get improved outcomes, or that the 5-day course needs to be extended. So 1 5-day course at this time is all that's authorized, and 3 to 5% is what the studies seem to demonstrate in terms of the actual rebound rate. Although anecdotally, it seems much higher than that. Moving on. So let's talk about remdesivir. Remdesivir was, like I mentioned, was authorized as a treatment very early on in COVID for inpatient. It has now been authorized, and if it's inpatient, it's actually for 5 days of treatment. And we'll talk a little bit about that. But in spring of last year, it was approved for outpatient, and it's only 3 days. So it's used for patients. We can use it in little itty bitty ones. So as long as they're 28 days and weighing as little as 3 kilograms. Our non-hospitalized patients, mild to moderate, who are at risk of progressing to severe disease, you have within 7 days of symptom onset to start this, and it's administered for 3 days in non-hospitalized patients. It is an infusion, and then your hospitalized patients get it for 5 days or until discharge, whichever comes first. And if they're discharged, they do not continue that treatment. Okay, next slide. So what are some of the monitoring? It is recommended that they get an estimated GFR, liver function, prothrombin as clinically appropriate. Although in the outpatient setting, numerous protocols did not have an estimated GFR prior to starting in the outpatient setting. Need to be able to administer in a setting where you can manage anaphylaxis. It's not common, of course, but it can occur. And then patient also needs to be monitored for an hour after that infusion. Does not have any clinically significant drug interactions that we know of. And you can use it in renal impairment, but you do need to monitor. One of the probably most common side effects is that it can increase liver enzymes, and it can be used in pregnancy. So if we need a treatment in an individual who's pregnant, Paxlovid is kind of on the line. We don't have real great data. We don't have any data about Paxlovid. Remdesivir can be, and then molnupiravir is not recommended in pregnancy. In terms of how recent the labs would be need to be, that's going to be based off of your clinical judgment. There's not really a recommendation out there. So if you feel relatively comfortable with that patient's labs, that you don't think there's been a clinically significant change, then I think I would want liver before I got for outpatient treatment. I would want liver before I got GFR, but you would see inpatient, they're going to probably do all of these before they start. But outpatient, with it being 3 days, oftentimes, if they have them, within a reasonable amount of time, then they wouldn't necessarily do them. All right, next slide. All right, so molnupiravir, this is our third and really only other outpatient option. It is 800 milligrams twice daily for 5 days. Non-hospitalized patients over 18, mild to moderate, with progression. You should only use it when either Paxlovid or Remdesivir are not available or not options. And again, this is another one of those where works to stop replication, so you want to start it as soon as possible. Interesting thing about this one, the data, we don't have data that shows that it causes damage to the fetus in pregnancy. However, there is some data in animals that indicate that it might. So they don't recommend, it's not contraindicated in pregnancy, it's just not recommended. And so it's for women, if they are childbearing age, they should be using a method of contraception, secondary method of contraception during the duration. And I believe for women, it's a week after. But with men, they need to use a method of contraception during treatment and for 3 months after the last dose of molnupiravir. So you can see why this has not been a real popular medication beyond its efficacy not being as great as as Paxlovid and Remdesivir. And then common side effects, diarrhea, nausea, and dizziness. Next slide. So I get a lot of questions, and oftentimes people are like, well, we would do dexamethasone. So I just wanted to hit on these again. These are your treatment management for your hospitalized patients. So if they are hospitalized for a reason other than COVID, so let's say car wreck, goes in the hospital, gets COVID, we would treat them just like we treat a non-hospitalized patient. So they're not classified as hospitalized for the sake of COVID. Okay, so you would follow the other guidelines. But if they come into the hospital because of COVID, then we follow these orange through dark red. So hospitalized, but not requiring oxygen supplementation, we're still recommending against the use of dexamethasone and other systemic corticosteroids. But if they're at high risk, we would go with remdesivir. Hospitalized, but requiring conventional oxygen. So oxygen above, so let's say we have a patient that's on oxygen normally daily. We're talking about more than what they typically do on a daily basis. So we would still be in that remdesivir. Most patients would then start to get dexamethasone plus remdesivir. And if they can't get remdesivir, then you would be looking at dexamethasone. Now, this is where we have a couple of other agents coming in. And again, if their oxygen supply increases, increased inflammation, systemic, we can use baricitinib or IV tocilizumab. Sorry, took me a minute to get that one out. And we'll talk a little bit about that one again. Now, if you continue, the patient continues getting worse, you're still looking at dexamethasone plus either the baricitinib, I hate these medications, the baricitinib or the tocilizumab. I butchered both of those, but anyway, they shouldn't name these medications these things. I said the same thing about the monoclonals before that. Now I can say them like anybody. And then as they progress worse, those are really our two only options, and we're adding on dexamethasone. But we're not using dexamethasone until they are actually requiring oxygen. And that's the big piece here. All right, next slide. So I wanted to put this out here. Actemra, you may have seen it used in other conditions. That's the tocilizumab. Apparently it just needs to be in bigger font so that I can see it better. It was just authorized in December, and that's why it's now appearing on the list. The patient has to be hospitalized and receiving systemic steroids and supplemental oxygen in some form in order to qualify for the treatment. We cannot use the Actemra in non-hospitalized patients. All right. And then I had touched on Evusheld before, combination of the two monoclonals. It is for pre-exposure prophylaxis in our moderate to severe immunocompromised. It's given every 6 months, and really is that other tool in the toolbox in addition to vaccination. And I think, yep, in summary, so that gives you your vaccination and boosters are the best tools to prevent. You've got Evusheld to supplement with your immunocompromised. And really right now, our non-hospitalized COVID-19 patients, first line is Paxlovid, followed by Remdesivir. If you can't use one of those, you've got Molnupiravir, and we can manage most Paxlovid interactions with the exception of those few. And I'm happy to answer any questions you guys have.
All right, so we do have one question in here. It is in reference to, I think it was slide 19 about the Remdesivir monitoring. And it was about how recent should the labs be?
Yeah, so it really is going to depend on like when you're looking at that patient, how much do you think they've changed clinically? I mean, if you feel like that the patient really hasn't changed clinically from the last time you have their lab, then you're not going to need there isn't anything written in the EUA that says you have to have labs. So if you feel comfortable with where the patient's labs are, you're fine to go. But if you feel like something may be going on, then absolutely you can get new labs.
Okay, thanks. So that's the only question we have so far, but we'll give people a couple minutes here to get their questions into us. You can put them in either the chat or the Q&A, or if you would like to ask your question out loud, you can raise your hand and I will give you the ability to unmute yourself. While we're waiting, I'd again like to invite everyone to next week's webinar. We'll be discussing the White House administration's winter playbook for nursing homes, and that will be next Wednesday at 2 p.m. And if you want to talk on any of these topics further, but prefer a one-on-one discussion, we invite you to join us during our office hours, which are each Tuesday at 8 a.m. and Thursday at 2 p.m. And those are kind of like a live chat room. So if you would be interested in attending one of those, we put the links in our newsletter that goes out each Friday called the Last Minute Lowdown. And if you would like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org and I'll get you on that list, and I will drop my email in the chat shortly. And someone asked earlier about presentation slides, and especially have all those great resource links in there. So with Krista's permission, we'll email those slides out later this week to the email that you registered for with this webinar. And for anyone listening to a recorded version of this later, I'll have a link to the slides in the episode description and at our website, qualityinsights.org/QIN/multimedia. Let's
So I
see.
think
I've got a
Lisa
couple
had a
things in the
question.
Q&A right now. Sorry, what were you saying,
I
Krista?
think Lisa had a question. Any thoughts on how long these recommendations will remain effective as the COVID-19 variants continue? So right now, I was talking with the ladies earlier. We are on the same branch. So if you imagine, I also use the analogy to like the bronchioles in our lungs. So we are like way down in the very tiny bronchioles in terms of variants. And even with this this XXB, which is the first US derived variant that we've had, all the others have come from another country, we are still in the Omicron arm, if you will, or the Omicron branch of and so as long as we're still in the Omicron branch, remember, Delta was a branch and the Omicron branch. So we don't have reason to believe that our antivirals, everything is indicating that the antivirals are continuing to work and are not waning in efficacy. All of these are tested anytime there is a new variant. And then also they go back and test all the monoclonal antibodies that we've used in the past anytime there's a new variant to see if, hey, can we use something in our stockpile? And then also, just like we added a new one with the Actemra or the tocilizumab, companies are looking at what drugs do we already have out there that can be used. So these just came out a few days ago. So my guess is we're good for a month or two, or we could be good for a few months. Just when I think we're good, somebody surprises me. Inevitably, I can tell you, I have a vacation planned in February. So either there will be a new vaccine or a new drug coming out then, because inevitably they always do that to me. Whenever I plan to take a couple of days off, there's always a new drug or a new vaccine, and I end up working on my holiday.
Try to plan around that. So we've got a couple questions that came in through the Q&A. This one says, in regards to cost barriers, are you seeing if it is easy to get remdesivir paid for, reimbursed? And this is specific to nursing home setting.
Okay, so remdesivir is covered by Medicare. So that is, as long as the patient has Medicare, it should not be a problem. It is reimbursed. It is a covered medication on Medicare. So and most third parties. So that should not be a problem at all. As it was, and so I have not now private insurance separate from, if it's not a Medicare patient, it may be more difficult to get it covered. It is about $2,300 for a course of therapy. But if it is a Medicare patient, it should be covered.
Okay. And here's another question. Hopefully I'm going to read this right. It says, suppose no vaccination given. Do we just give the bivalent?
No, if a patient has not been vaccinated, they must have the primary series. So they must have the primary series, which is defined as either 2 doses of Moderna monovalent, 2 doses of Pfizer monovalent. So all of your places that are offering vaccinations, your health departments, your pharmacies, all of those still have monovalent in. At this point, because of the way the drugs are authorized and approved, basically the immune system has to be primed before the booster can work how it is. So you get a bigger dose in that primary series before you get the booster. So they have to get those 2 primary doses, or if they're immunocompromised, they have to get 3. And then they get the booster that's bivalent. So absolutely, that would be how that is. I can tell you that VRBAC, which is the advisory committee to the FDA, is meeting the end of January. So there could be some vaccine changes that lines up with my end of February, 1st of February prediction. So there could be some changes then coming in terms of what the primary series looks like, but they still have to have a primary series before they get the bivalent.
Okay, so we are getting close to the end of our time. I see a hand raised though. So Cindy, if you'd like to unmute yourself and ask your question.
Oh, well, Krista, just really quickly, one of the barriers we have in skilled nursing and in the nursing homes, both in West Virginia and Pennsylvania, is the fact that we're not seeing a big push in the acute care hospitals with the COVID vaccines nor the bivalent. Do you think the FDA, or I know that ACA is working on that collaboration, but do we have other entities that are having that conversation as well?
Yeah, we do. We are working on it at a state level. I'm working on it at a national level as well with several organizations. And so we're trying. It just, so many people are just tired of COVID. I'm probably more tired of COVID than anybody. But yeah, people just don't want to hear it, and I get that, but we still have people dying every day.
All right, thank you.
All right, let's take 1 more minute. If you can't type fast enough to ask your question, just go ahead and raise your hand and I can let you speak your question out loud. And if anyone needs it, I put my email in the chat. Krista, would you like us to share your email too?
Absolutely. Feel free to share my email. And you're welcome to share my cell number. I think everybody in the state has it too. And because it's at the bottom of my my emails. So feel free to share that. And I'm pretty much always on call and available because questions come up. So
Okay, I don't have your email open. Can you go ahead and say it out loud?
Absolutely. I can put that.
Yeah, we'll put that in the chat, but I'll include that information in the email that I send later this week to everyone with the recording and the presentation slides. I'll put your contact information in there too. All right, there we go. So it's Krista D. Capehart at WVU.
Oh, that's wrong.
Oh,
I combined my 2 emails. There you go.
At WV.gov.
Yes.
Krista D. So that's Krista.d.capehart at WV.gov.
Yes.
And I'll include that if anyone's listening to a recorded version later, I'll include that in the episode description too. Okay, I think we can wrap up here. I don't see any hands raised or questions. So if anyone does have questions, they can follow up with you or they can follow up with me. Dr. Capehart, thank you for joining us today. And I'd like to thank all of you for joining us today and hope to see you back next week.
Thanks, everyone. Have a great day. Bye-bye.
Bye.